All right, you're welcome. This is Celebrity Pharmacologist, and today let's look at Amlodipine versus Nifedepine in after brief lectures on hypertension and antihypertensive. So today we'll be selecting few antihypertensives, that's few drugs used in management of hypertension. We'll be taking drugs like Amlodipine, Nifedipine, uh, Veramapril, Captopril, Lisinopril, Valsartan, Telmisartan, and so many others. Now let's dive into this amlodipine versus nifedipine. First thing first, by way of classification, they are classified under the antihypertensive called the calcium channel blockers. Calcium channel blockers, which is also known as CCBs. And under this classification, it is called, they are called, I'm talking about amlodipine and nifedipine, they are called the dihydropyridine calcium channel blockers. Dihydropyridine calcium channel blockers. They are very, very potent. They are very, very potent. Talking about amlodipine and nifedipine. Now let's talk about their mechanism of action. They have the same mechanism of action. They block the L type of calcium channels in vascular smooth muscle. What this means is that calcium is actually present in most smooth muscles, of which they cause what we call vasoconstriction. And know that when there is vasoconstriction, it will lead to it will increase the peripheral vascular resistance, thereby increasing blood pressure. Let me explain this. This is the only mechanism I'm going to explain. Let me explain this with a paper. Let me use the paper to explain this. This is a sheet of paper, and let's assume that this sheet of paper it's is the blood vessel. So let's assume this sheet of paper is a blood vessel, and my mouth, my mouth is the heart. My mouth is the heart, and the air I'm going to pump out, the air I'm going to pump into this vessel is the blood. Now, for instance, let me explain this. I'm going to explain this in a Nigerian way, a layman language. So, if you are not in Nigeria or you don't understand some Nigerian language, please you can just forward it to where we start talking about others. But in Nigeria, now let's say this is the I said like my mouth is the heart. This is the blood vessel, and the air is the blood. So, for instance, now this blood vessel sends blood to the hand. Let's assume it send blood to the hand. Now the heart is supposed to pump the blood. You see, small pressure is sending it very well. That is it. But when calcium now cause what we call vasoconstriction, what's constriction? Constriction simply means to contract. So it will now cause the vessel to be tinier. If a vessel is something like this, but when there's constriction, the upper one will come, the lower one will come, they will now become very tiny, reduce. So making it difficult or harder for blood vessels to pass through. You see, making it harder for blood vessels to pass through. Now understand this concept. Now, if I should put air through this vessel, you see it goes easily. But when there is constriction, that means it contracts. Then what you see is that it will block, like it's going to close a little bit. So even if I put the air now, it still goes, but I need more pressure. Now, assuming this air we are sending goes to the hand, the hand is it doesn't it's not it does there's no sympathy. It will not be compassionate to say the blood that they are sending to me is small, or it's too small, let me manage. It's not going to manage. It will still send signal immediately when there is shortage of blood to some tissues or to some part of the body. It will send signal to the brain, maybe through pain, say please, the brain, please, we need blood. So the brain on its own will then send signal to that same heart, pump blood to this part of the body. Now immediately the heart will say, okay, okay, yes sir, we try to pump this blood. The same pressure, the heart will then start to work fast, starts to work harder to make sure that blood gets to that part of the body. So automatically you are putting this calcium will then put the heart into harder job to it cause what we call increase in pressure, because there's what we call peripheral, there's increase in peripheral resistance, peripheral vascular resistance, and there's what we call vasoconstriction. So what amlodipine will do, is to stop this calcium from, it will block this calcium in the vascular smooth muscle, in the vascular, in the vessel smooth muscle. And when this thing happens, there will be increase, there will be dilation. So when there is dilation, it will reduce peripheral vascular resistance, and automatically the blood pressure will reduce, the pressure needed. Like it will then, like what I'm saying here, it will cause dilation. The dilation means it will open up. Your hand will, from constriction, it will release itself. So the blood can go freely, no more pressure. So that's just the mechanism of action. That's what calcium is doing there, and that's why we have calcium channel blockers. Now let's talk about their onset of action. The onset of action is of amlodipine is gradually. Why I can't make this mistake? Gradually. It's, you get to its peak, or it becomes very efficacious 6 to 12 hours after the administration. While for that of nifedipine is very fast, sharp, in less than 1 hour, let's say 20 to 60 minutes. As on the board, you will see the effect, especially for the immediate release. Immediate release, you get the effect 20 to 60 minutes. Now let's talk about their half-life. The half-life of amlodipine is 30 to 50 hours. 30 to 50 hours is still in the body, it breaks down gradually. That's why the initial dose for amlodipine is normally 5 mg, and is taken once a day. If you are here and you are taking amlodipine twice a day, you are doing the wrong thing. It's once a day. This is start dose, 5 milligram. While for nifedipine, it was 2 to 5 hours for the half-life. Now talking about the duration of action, amlodipine works for 24 hours, approximately 24 hours, still in the body working. That of nifedipine is it's 4 to 8 hours. Most people take nifedipine like 2 to 3 times a day because of this, how it works in the body. 2 to 3 times, that's how they administer nifedipine. However, for amlodipine is just one a day, one tablet daily, one daily. Now let's talk about the effect on the heart rate. Amlodipine has minimal reflex tachycardia due to gradual onset. I got this spelling correct. Due to gradual onset, it has minimal tachycardia. I want you to, if you understand, if you know the meaning of tachycardia, please tell me in the comment section. Tell me the meaning of tachycardia and bradycardia. What do you understand by bradycardia and tachycardia? However, for nifedipine, it has greater risk of reflex tachycardia, especially the immediate release, the IR. The extended release is a little bit calm and safer, but the immediate release has greater effects. Now talking about the indication, that's the best indication where you should introduce amlodipine and nifedipine. Amlodipine is good for long-term blood pressure control, and especially for elderly people, it's very good when you need a stable blood pressure. That is when you should introduce amlodipine. However, for nifedipine, when you need a fast acting drug, when a fast acting drug is needed, then you introduce nifedipine. For instance, emergency case when the blood pressure is very high, so when it's so high and you need it to come down immediately, then you should be thinking of nifedipine or nifedipine. Now let's talk about the advantages, or the advantage amlodipine has over nifedipine, and the advantages nifedipine has over amlodipine. Amlodipine has long half-life. That's what we have said. The half-life is about 30 to 50 hours, and it has a stable BP control. It gives a stable BP. However, the advantage of nifedipine is the fast onset. In case of emergency, you introduce nifedipine. You don't keep amlodipine, something that will stay up to 6 hours before you start seeing its effect. How many millimeters of mercury of the BP is going to bring down when you need something immediately? So fast onset, we talk about nifedipine, but we need stable and long term use, we talk about what? Amlodipine. Now let's, the demerit, that's the disadvantage why amlodipine is The drawback of amlodipine is the slow onset. It is the slow onset of amlodipine, which is about the onset is about 6 hours. However, the demerit of this nifedipine is the short half life of 4 to 8 hours. It's not analgesic that you just take. You cannot leave the heart exposed to high pressure after just 4 to 8 hours. You are exposing it to high pressure. That is not good. So most people are not comfortable taking drugs 2 3 times a day. I've seen someone who said I don't want to be taking my drugs, I'm tired. I said why? He said she's taking the drug 2 times every day, 2 times daily every day. Even some people that are even taking anti-malaria, I'm coming for that. Some of you, I saw someone that made a post on TikTok. He said, me and 99 others will not take our anti-malaria drug. Let me tell you, what you are trying to cause in your body is what we call anti-malaria resistance. Malaria parasite can develop mutation, and what this means is that the time that you will need the anti-malaria, it will not work in your body. They're not going to talk about that, but that's a very bad habit. Some those people posting that, please don't emulate it. Don't skip your anti-malaria drug. But this anti-hypertensive, that's what we are talking here today. That's what we are talking about. All right, we have come to the end of today's lesson. I've also seen that some of you are complaining that you don't want much of the MCQ questions, MCQ, that you want comparison like this. I will want to beg you, please, after brief introduction or talk like this, we need MCQ to digest this thing very well, because there are some things I'm supposed to say here. Like, I did not talk about their adverse effect or side effects. There are some side effects it has. I did not talk about what to do if amlodipine is failing, because most people think that once amlodipine fails, you go back to the nifedipine. No, the most appropriate thing to do when you are saying that the effect of amlodipine is not enough is to add another uh, class of antihypertensive like the ACEs, angiotensin converting enzyme inhibitors, the ACEs or ACEs, like the lisinopril. Yes, so it's not that's the reason for the MCQ questions. Please bear with me, because we are definitely going to answer not less than 10 questions from this very topic, so that you will know when to use amlodipine and when to use lisinopril. The best time actually to use amlodipine, it's when the blood pressure is already stable. You just want to get it, you just want it to be stable. But in most cases, you will first introduce nifedipine. You use it for like 2 3 days or even 5 days. When you see that the blood pressure is stable, it has come down, then you go to amlodipine. That's how it's been managed. But with time, we'll just do some questions on this, and we also talk more on other important drugs like the ACE inhibitors and the ARBs inhibitor. Please, if you like this kind of video, do well to follow the celebrity pharmacologist. Drop your comment in the comment section, like and save this video. Thank you.